From the News Channel 5 Network, this is Medical Mondays.
Hi everybody, I'm Kristen Presall. Welcome to this edition of Medical Monday. Tonight we're going to be talking about something that I know a lot of you will be calling in about. It's always a very hot topic here on Medical Mondays, and that is joint replacement. So we invite you to call in tonight and join in on the conversation. We have two wonderful orthopedic surgeons with us tonight, both from St. Thomas Hospital. I'll go ahead and introduce you to them right now. Dr. Michael Christie, right to my left. He has been on Medical Monday before. Glad to have you back.
Thank you.
And also Dr. Jeff Hodrick, who is also an orthopedic surgeon over at St. Thomas Hospital. And you're relatively new to the area, right, Dr. Hodrick?
Yes, ma'am.
Been here for how long now?
Just about a month.
Oh, very good. Well, we're glad to have you.
Thank you.
Well, I tell you what, gentlemen, we, like I said, joint replacement is always a big topic on this show because a lot of people call in, let's face it, knees, hips, any kind of joint that you have an issue with. You know, these gentlemen here would be able to tell you if you're going to be a candidate for surgery. And we'll talk, of course, about what kind of surgery option is out there for you, how long recovery time might be, and just what total joint replacement surgery is as well. We were talking a little bit before the show because Dr. Christie had shared with me, you said, what, 400,000 knee replacement
That's correct.
surgeries happen per year, and then about 250,000 hip replacements. And what's going to happen in the next couple of years? What will those numbers do?
So we expect, because of the change in the age of the U.S. population, that those numbers will double over the next 7 years.
Goodness. And when we're talking about patients who come in to see you, and I'll ask you this, Dr. Hodrick, what's their biggest complaint, and how do you know that they're a candidate for surgery?
Pain. Most of the time it's pain, and it's pain that limits what they want to do. We call it lifestyle limiting pain. And basically it's people that can't operate or function where they were maybe 5 or 10 years ago, where they have pain at night that keeps them from sleeping. Those are the types of complaints that we hear all the time. But mostly it centers around pain that they have to think about every single day.
Now, when you diagnose them, are you all looking at X-rays? Are you doing some sort of test? Talk a little bit about that process.
So it's primarily a radiographic or an X-ray diagnosis. In knees, it's weight-bearing films. Hips, not weight-bearing. And what we're looking at is the status of the cartilage coating on the end of the bone. So all bones and joints have cartilage. Cartilage is the pearly white stuff on the end of a chicken bone. And it's the process of wearing away that coating that is arthritis. Once you wear it away, once the bone rubs on the bone, it's when the patients have significant symptoms. So they have pain that bothers them whenever they try to do anything. Their arthritic hip or arthritic knee starts to make decisions. Which chair, how far, whether we're going to shop, what vacation we go on, kind of car we own. Sure. Those kind of things are made just by the limitations of their arthritic joint. It
would make sense to me if one of your patients, you would say, used to be a marathon runner, because when you think of wearing down that cartilage, you know, it would be somebody who would be an extreme athletic type of person. But I understand that you all see all sorts of different kind of patients. Give us an idea in terms of age range or even gender, if you see more men than women. And
yeah, we mentioned the population changing part. That's the baby boomer generation. Sure. Those are obviously the lion's share of our patients now that are very active and have participated in sports and been active in running and jogging and hiking and biking and all those things. And certainly those things can lead to some post-traumatic type conditions. They've been hard on their joints. There's still much benefit. We're certainly not trying to portray or tell you to stop walking or stop running. I mean, sure. It's more important that you stay fit, actually, for your joint health. So we're seeing that patient population come up, and then we're also seeing those that are just living longer and have an opportunity to wear down their joints for various reasons. So we're seeing kind of the younger population and also an older population that's healthier. Our medicine's better. They're staying alive longer. And now they want to keep active. You know, they want to keep walking, and they want to keep with their grandchildren, or whatever they want to do. Make sure they can walk to church. All those kinds of things that people want to do. It's not acceptable to sit at home anymore.
You know, there is that group of patients who have a family history of arthritis.
Absolutely.
So they're born with low mileage tires, if you will, yeah. and so have early arthritis. Younger patients that have arthritis is usually a result of either a congenital problem or a problem that occurred when they were in adolescence. a change in the shape of the joint, a growth deformity in the joint, or trauma. So they were in an automobile accident in which they suffered a fracture through the joint and injured that smooth white surface, now have accelerated wear, so that in their 50s they end up with a bone-on-bone type arthritis.
Wow. Okay. Now, here lately when I go to the gym, I see both men and women of all ages working out. Do you all notice that men or women tend to be harder on their bodies in terms of any kind of activity, to where you would see more of them in your office?
Yeah, I think the general belief was once that it was men.
Yeah, all men,
and
sure.
I think that now that women are more athletic than they were 20 years ago, and I don't think you can really say that a certain sex has a greater risk just because of their activity. All
right, very good. I'm going to remind everybody, if you would like to call in and ask Dr. Christie or Dr. Hodrick a question tonight, the number is going to be on the screen all night long. It is 737+, 737-7587. We should talk a little bit also about joint replacement surgery, if you guys can kind of discuss that and what somebody would, well, I would say have to look forward to. I don't know if that's the proper term I should use, but talk a little bit about that, if you don't mind.
I can speak to that. I think when you talk about looking forward to it, it's actually pretty surprising after they have it done. Usually what they talk about is, I wish I wouldn't or hadn't waited so long to have it done, believe it or not, because a lot of folks will live with that pain for so long. Sure. And put up with it for so long. But certainly the joint replacement we talk about and we deal with most often is of the knee and of the hip. And those are the two types that we see most often. And joint replacement's probably not the best name for it, because it's not necessarily replacing a joint. It's more of a resurfacing. And this is an example of the actual prosthesis that we use. So if you look at it from the side,
if you don't mind pulling that up for us, Dr. Hodrick.
Looking at it from the side, we actually take away the abnormal cartilage and then cover that with a metal piece of on the top, and that's
so
on
your
the
bone
end of
is
the thigh
underneath
bone.
that.
Exactly.
Okay.
So it's not replacing any sort of bone. It's just recapping or resurfacing that bone.
Okay.
And then the same thing on the bottom side. There's a metal piece that then holds a piece of plastic in between.
Okay.
And then that allows it to glide back and forth and give the normal knee motion. So not necessarily a knee replacement, but it's more of a resurfacing type, in that we're giving a new gliding surface to the knee.
Has this kind of, well, I don't know if I should say equipment, if that's the right term, but has it come a long way since you all have been either studied orthopedic surgery or have been practicing?
Less than you might expect. If I took a knee replacement from 20 years ago and put it up here next to the newest, latest knee replacement and said, can you tell the difference? I think most people would have a hard time.
Okay.
So we've seen an evolution. Part of it, is simply by the kind of materials that we have available to us. Part of it is by the anatomy of the joint itself. So what we've gotten better at is reproducing the original engineering, if you will.
Okay. What's
changed most in the last 20 years is that we've gotten, as surgeons, much more precise in terms of where we put those surfaces. So the normal function of the joint is better, and the knee or hip replacement is going to last longer.
Great.
Because it's seeing better stresses.
Yeah, good news for the patients then. All right, we do have a viewer already wanting to call in and ask you gentlemen a question. If you don't mind, we'll go ahead and talk with him real quick, and that is James. Hi, James.
Hello.
Thanks for calling in, sir. What's your question for the doctors tonight?
I was just concerned. I've had one knee replacement done already on my left knee, and it's the greatest thing I ever had done. Took all pain away. Now my right knee, I've had an injury on it where I tore my ACL and my lateral meniscus, and I was wondering if I had that knee done because of the arthritis I have in my knee, how much stress would it put on the right knee at the time during the surgery would it be?
Well, hold on the line, James. The doctors may have a question for you. Or...
Sure, James. So you're talking about, let me just clarify the question. You're asking how much stress on your knee replacement if you had your other knee replaced? Is that what your question is?
Yes, sir.
Yeah, so certainly it's a great question. It's kind of the question of whether you need a good leg to stand on, and you're not going to wear out the plastic, or you're not really going to change the metal or do any damage to that knee replacement, during that recovery. I think you'll probably remember recovering from your first knee replacement, the other knee is going to have to take the lion's share of the work, at least for the first few weeks.
Yes.
You're certainly not going to do any damage to it, and I'm assuming it's plenty strong because you're pleased that you had it done and it's performing well for you. So I wouldn't worry about it at all.
Okay. Well, I was just concerned.
Yeah, I don't blame you. And a lot of people, I think, tend to be in that same situation that James is in. Once one knee goes, maybe a couple years later, they're looking at the other one. So, well, best of luck to you, James.
Thank you.
Thanks for calling in, sir. All right, we're talking about joint replacement surgery tonight with two orthopedic surgeons from St. Thomas Hospital, and Medical Mondays will return right after this.